Lupus. We have an insightful presentation planned for you today. First, a few housekeeping items. You'll notice attendee video and audio are disabled in this webinar format. You may add questions to the Q&A, and you may also add some dialogue to the chat box. Both of those functionalities are at the bottom toolbar. If you have any questions, technical questions, you can message me directly. Next, I'd like to welcome Dwayne Harris. He is the Chief Executive Officer of the National AHEC Organization. Welcome, Dwayne.
Thank you, Laura, and welcome everyone. Good morning and good afternoon. As Laura mentioned, I'm the CEO of the National AHEC Organization. I want to thank you for joining today's presentation on lupus, which we are bringing to you in coordination with our longtime partners, the American College of Rheumatology. Now, for those who may not be familiar, AHEC, which stands for Area Health Education Center, is a HRSA program that began some 50 years ago with a mission of improving the quality, supply, and distribution of health care for underserved populations. There are about 300 AHECs across the country engaged in this work. We cannot do the work that we do without your participation and without the help of valuable partners such as the ACR, and we thank all of you for that. Now, today's presenter is Dr. Sarwat Umer, and she is coming to us from Louisiana State University Health at Shreveport. She is an endowed professor of pediatric rheumatology, an associate professor of medicine, pediatrics, associate program director of the Rheumatology Fellowship at the Center for Excellence for Arthritis and Rheumatology at LSU Health Shreveport. She's also a member of the American College of Rheumatology and a member of the Childhood Arthritis and Rheumatology Research Alliance. Please welcome Dr. Sarwat Umer.
Thank you, Dwayne, for the introduction, and welcome everybody. Hello, I'm Dr. Sarwat Umer. I'm one of a medicine and pediatric rheumatologists. That means I take care of adult as well as kids with lupus. And I am very happy to get the opportunity via AHEC and ACR for this great lupus initiative. I would like to say that lupus is one of the most challenging conditions to diagnose. And unfortunately, we have a lack of access to rheumatology in smaller towns where these patients with lupus may be presenting to different primary cares as well as quick cares. And so goal of my talk today is that we can access most of the primary care people who are at the front line to take care of these sick lupus patients. So we'll get started. So the topic is diagnosis and management of systemic lupus erythematosus. Learning objectives. After my talk, I hope that we should be able to recognize signs and symptoms of lupus. We will see lupus has such a heterogeneous group of population. Patient can present with many kind of features, and we should be able to recognize that because early recognition definitely will improve the patient prognosis because we'll be able to treat them on time. Know when we have to effectively refer the suspected lupus case to rheumatologist because delay in the diagnosis can cause permanent organ damage, and know how to initiate workup for lupus. We should also know what patient demographic in which you will see lupus patients more, and also how lupus epidemiology also affects the patients in a form of healthcare disparities, and patients have limited access to doctors many times. And I work in a tertiary care center and I see poor indigent patients and have seen sometime the reason they were not referred to us in a tertiary care center on time because they didn't even know they have a place available where they will be treated and given all medications without any problem of having funding or insurance or not. I have no conflict of interest to disclose. All the medications that I will be discussing about lupus, some of them are FDA approved and other we use for a long period of time off-label in word of lupus in one of the very challenging conditions. So very excited to speak about lupus. There is a whole lot we can discuss about this disease. I'm hoping that we have already completed a pre-test for all the participants because after the lecture, I encourage you to do a post-test assessment that will greatly help us to decide how much success was there after my lecture that you can recognize lupus patients well. So we want to build with the small sessions that got started with ACR, with Lupus Initiative, a great connection between healthcare provider and rheumatologist in the area and communities where they are underserved by rheumatologists, and just having access to a rheumatologist and even sometimes discussing curbside about a patient can give a great help to lupus patient. And you may be seeing a lupus patient in your practice that it's a matter of just talking to a rheumatologist and recognizing them on time. So we want to raise awareness about lupus because some of the lupus features, lupus is a great mimicker with B symptoms or constitutional symptoms. So we want to start recognizing when we will elevate lupus in our differential diagnosis, especially in high risk group. What is lupus? Lupus is an inflammatory, multisystemic autoimmune disease of unknown etiology with varied clinical manifestations that can change frequently and unexpectedly. We have seen lupus patients presenting at the time when they are so sick that we meet them in critical care units, but we may also see them sometime presenting with chronic lingering symptoms. Lupus can be mild, it can be severe, or anything in between. Lupus is characterized by periods of flares and then periods of remission, and sometimes they will have irreversible organ damage by the time we get to see these patients. Since the patients have flares and then periods of remission, if you find a lupus patient in remission, sometimes you may not recognize how much disease they have had at the time of the flare. We all had heard the expressions, when you hear hoofbeats, you think of horses, not zebras. That is true for the common practice, but in many cases, lupus is a zebra. So average internist or primary care may sometimes see lupus patient 1 to 2 times a year in their practice. So the worldwide prevalence of lupus is 140 out of 100,000. So the likely reason of a female presenting in your clinic with fever and fatigue may still be a viral infection, but there are going to be times when you'll find somebody who has these symptoms and they are going on for weeks and they may be a lupus patient. So let's talk about what are the demographics of lupus and which populations are at high risk. So when you're treating a person of color of childbearing age that have unexplained prolonged symptoms and prolonged fevers, they may have a higher likelihood of having lupus. Lupus affects 1 in 250 young African-American women in the United States. It's also more prevalent in Hispanic, Latina, Asian, and American Indian women. So Hispanic and Latino women the risk is even higher with the prevalence of 142 cases per 100,000. That just make us realize that it affects the colored patients much more compared to Caucasians, although it does happen in Caucasian patients too. Furthermore, when lupus affects African-American and Hispanic Latino women, it happens at much younger age. And as they present at a younger age, they have more severe disease. So remember, the autoimmunity, if it didn't wait long enough to present, it's gonna be very severe. So we see pediatric patients, Hispanic as well as African-American, presenting with very sick lupus. So when you're treating a woman in color in childbearing age, in them lupus may not be a zebra. Actually, it may be a horse. That means it may be more common in them. So going back to the epidemiology, worldwide, 2 to 140 per 100,000, but as high as 207 per 100,000, depending upon which population you're dealing with. Incidence is 1 to 10 cases per 100,000. People with lower income are less likely to receive recommended care, and poverty is definitely associated with poor outcome in lupus patients. Women are 9 times more likely to develop lupus than men. So knowing that this is a disease which affects females, mostly colored female, but also Caucasian too, but African American men can have lupus and they are usually diagnosed very late because we always think that it's more of a female disease. It affects mainly women in their reproductive age, African American, Hispanic, Asian, American Indian, Alaskan, Native women, they all have highest prevalence and very bad disease. Lupus affect 1 into 250 African American women in United States, something that we need to repeat a couple of times so we can remember to look at the features of lupus in these patients more carefully. African American women have 3 to 6 times higher risk than white or Caucasian women. And risk of Hispanic and Asian women is between 1.4 to 1.7 times higher than for the white woman. African American Hispanic will always present this with this condition at a younger age and with much more severe symptoms at the onset. Sometimes we'll find them in the critical care unit. One thing which is very sad about lupus is that African American and Hispanic women have a much higher mortality rate, 3 times as higher with white women with lupus. So all these demographic make us realize that healthcare disparities have a great impact on the prognosis of lupus patients. This is just a slide showing a graph of between Caucasian and African American patients. You can see this graph is showing early age of onset and having much higher risk of flare and severe symptoms in African American patient compared to Caucasian patients. Other healthcare disparities in the lupus include that low-income individuals are less likely to receive the recommended care. Poverty is always associated with a poor outcome. That has many factors in it. It includes factors like poor health literacy, not having access to medications, and that all lead to poor outcome. This is another graph depicting that disparities in lupus. One of the biggest organ manifestation in lupus is kidney disease, and renal involvement certainly leads to a very bad prognosis in patients who end up on dialysis or have end-stage renal disease. And you can see this graph shows that African American tend to have the highest disease burden, renal disease with lupus, compared to rest of the ethnicities, followed by Hispanics. So specific racial and ethnic minorities with lupus have mortality rate as high as 3 times as white individual, because not only they are poor, they do not have access to primary care doctors and specialists who can diagnose and treat them on time. So our job as primary care, as ER physicians, as doctors, nurses, nurse practitioners, is to recognize lupus patients on time. So let's review the signs and symptoms of lupus by which we can make a better diagnosis. A lupus patient diagnosis can sometimes take 2 or more years, and it includes visit to more than 3 providers before we start noticing that there's something wrong with this patient and has chronic symptoms and might possibly have lupus. Why is the diagnosis so challenging? Because lupus is a great mimicker. It can mimic many conditions like viral syndrome, malignancies, allergic reaction, and stress. Sometimes these patients have associated depression and fibromyalgia, which leads to some more symptoms or some of vague symptoms, which make it further challenging for primary care to make the diagnosis. The vague symptoms include fatigue, achiness, stiffness, low-grade fever, swollen lymph nodes, and rashes. As one can see, these all symptoms can be present in somebody who has an acute infection. And if the patient is not going to a same primary care and is going from one quick care to primary care to another quick care, then every time the first instinct would be this is a viral infection or this is an infection, give patient antibiotic, and it may truly be a lupus patient. Symptoms sometimes develop suddenly and sometimes they will be slow. Most of the time, those patients who have 2 or 3 visits to the physicians, they have insidious course or slow development of symptoms. Delay in diagnosis will be very devastated in a lupus patient. It could lead to organ failure. It can increase the 5-fold increased risk of death. So with early diagnosis, the chances of a lupus patient living a full life with manageable chronic disease are much higher and increased. I have stable lupus patients. I have a big cohort of lupus patients I follow in my clinic, and I have noticed the patients who are compliant and who take their medications, they have had a very stable disease for many years, and they are leading a fairly normal life. So a person who is feeling sick will often seek help from a primary care or emergency room at the onset of symptom. And it's crucial at that time that we recognize the potential symptom of lupus and make referral to rheumatologist when appropriate. So our mission is to educate primary care providers about lupus. So patient with lupus will get correct referral, diagnosis, and treatment they need. I have only one slide on pathogenesis of lupus. Of course, there are lots and lots of studies happening still trying to look at the pathogenesis of lupus. And they are beyond the scope of my talk. We're discussing more about the clinical features and the diagnosis and management of lupus. But the one of the plausible mechanism of why lupus happen, it's autoimmunity, altered immune homeostasis that lead to autoreactivity. We believe that there's some environmental exposure, which sometimes most of the patient we know with lupus will tell them sun can be a trigger. They are very sun sensitive, they're photosensitive patients. So we think that sun may cause some damage to their cells, or they may have some genetic alteration at the same time. Those damaged cells are now presented in the presence of MSC class 2 to plasmacytoid dendritic cell. Plasmacytoid dendritic cell will then cause activation of T cells, and finally leading to activation of B cells through cytokines. These cytokines, when they go act on pro-inflammatory molecules and cytokines, will lead to tissue injury. B cells, when they get activated, will make antibodies, and these autoantibodies will also cause further damage. There is also immune complex activation during this cascade, which lead to the organ damage, and patients can have damage from head to toe. The damage, if it is going on for a long period of time, and if you see lupus patient in a chronic phase, you may find them with end-stage renal disease. You may find them with the history of chronic cytopenias. You can find them with history of chronic serositis, pulmonary hemorrhage, and vasculitis, many other manifestations of lupus. This immune dysregulation leading to autoreactivity and autoantibody in lupus occur in different phases, and it likely represent the untoward effect of environmental trigger on the genetically susceptible host. We do believe that lupus doesn't have a Mendelian pattern of inheritance, so it does skip generations. So if patient has lupus, not necessarily the kids will have lupus, but it may still run in the family. And you may find it in the next coming generation. So we find a grandmother with lupus and may find a grandkid afterwards. Let's look at some of symptoms of the lupus. This is the criteria for lupus, 1982 ACR classification criteria, which were revised again in 1997. And these are the most easiest and the criteria to remember to diagnose lupus. It is best remembered by mnemonic called SOAP, brain MD. S stand for serositis, O for oral ulcers, A for arthritis, P for photosensitive rash, B for blood dyscrasias, R for renal disorder, A for ANA, I for immunologic disorder, N for neurologic disorder, M for malar rash, and T for discoid rash. So 4 out of these criteria need to be present serially or simultaneously observed by a knowledgeable healthcare professional to make the diagnosis of lupus. As you can see, all these criteria in lupus patients sometimes may not be present at the same time, and you may find a patient that has 3 criteria, and you start realizing this is going to be a lupus patient. Then following those patients by a same primary care provider is the best way to make the diagnosis, because patient may develop the 4th symptom down the road when you can give them the confirmed diagnosis of lupus. So some of these manifestations of lupus, let's discuss about them one by one. Synovitis. So lupus patients can have arthritis. Arthritis comes and goes during the time of flare. I want to mention that lupus has the chronic arthritis after 10 years of disease in the form of Jacquot's arthropathy. We have pictures for that. in which they have ulnar deviation. This ulnar deviation is reversible compared to in RA when the ulnar deviation is irreversible. So sometimes lupus patients in between the flare may not have swollen joints. So arthritis in lupus patient many times is more evident during the time of flare. They can have a malar rash or a butterfly rash. It's a rash which crosses the nasal bridge, but spares the nasolabial fold on both sides. Patients can have oral ulcers. They are painless ulcers on their palate. Many times patients do not report these ulcers. So we as rheumatologists are known to look at the top of the roof of the mouth of lupus patient rather than looking the back of throat when we're asking them to open their mouth, because we're looking for active ulcers, which are part of their disease. And if you don't educate your patient to look for it, they may not even know they have ulcers on their palate. Lupus patients can have Raynaud, in which they will have purple, white to red discoloration of their fingers on a cold exposure. These patients usually do not have digital ulcer with their Raynaud. They can have discoid rash, which is more circular rash in head and neck distribution. This happens much more on the scalp too and cause scarring, alopecia. This can be very disfiguring for lupus patients. This is the Jacquot's arthropathy, in which lupus patients can have some swan neck deformities and mild ulnar deviation. This happens with a long-standing disease that they can start having some flexion deformity here, and they may have mild ulnar deviation. This is all correctable because it's much more ligamental involvement. Lupus patients can have vasculitic lesions on their palms, and they usually present with red tender spot on their palms. They almost look mimicker to infective endocarditis-like lesions or Janeway lesions on the palm, but they can be part of their disease and flare. They will have other symptoms of lupus along with the red discoloration or the tender nodules on their hands. This is the alopecia that lupus patient can develop after having chronic disease. Unfortunately, scarring alopecia can be irreversible. So earlier management, diagnosis and management of lupus patient is very, very vital. Otherwise, in many female patients, you see very disfiguring alopecia if they have not been treated on time. Here are some symptoms of lupus that make that diagnosis difficult because they can be indicator of many other conditions. Lupus patients complain of achiness and headaches. They feel tired and fatigue all the time. They may also feel that they are under a lupus fog, memory thief or brain fog. We have seen our lupus patients with flare in which if you ask them to fill a simple survey, and they are very educated patients, they may not be able to do it at the time of their flare because they are under the lupus fog. They feel depressed, and one of the reasons of depression for sure is a chronic diagnosis in which they see that there are many days when they will struggle if they are having a flare, and then they cannot do their activities of daily living. Some internal manifestation of lupus, which can cause lupus patients to be hospitalized. Serositis, so lupus patients can present with pericardial effusion, sometimes that big of pericardial effusion, they are at verge of tamponade. They can present with pleural effusions. They also can present with peritonitis. Pericardial effusion, a young female with unexplained pericardial effusion, we always think of lupus and we keep that in the differential. Cerebral infarct, lupus patients can present with stroke, young persons with stroke, and that can be sometimes the initial presentation of a lupus patient. Brain atrophy with the chronic use of steroid in lupus patient as well as chronic inflammation can lead to brain atrophy in lupus patients. They can have different kind of cytopenias, including spherocyte, and also have lymphopenia, leukopenia, thrombocytopenia, and anemia. They can have glomerulonephritis. Kidney involvement is one of the biggest organ manifestation in lupus and certainly carries a poor prognosis if patient has proliferative lupus nephritis. The worst kind is diffuse proliferative lupus nephritis or class 4 lupus nephritis. This is different lupus manifestations that we can see that lupus patient mostly will have joint symptoms. They have neuropsychiatric manifestations, fever, prolonged fatigue, arthritis. Remember, arthritis can be in the time of prominent more at the time of flares, skin rashes, anemia, kidney involvement, pleurisy, pericarditis, butterfly rash. And so most of these symptoms are the one which are seen in more sick lupus patients. Photosensitivity is part of the disease, hair loss. Some patients will have abnormal blood clotting problem, Raynaud phenomena, history of seizure, mouth, or nose ulcers. Why is the diagnosis so difficult? Because lupus has such a wide variety of symptom and organ involvement. Initial symptom may be so non-specific: fatigue, achiness, stiffness, low-grade fever, swollen lymph nodes, rashes. And there are so many other conditions which look like that, including viral syndrome, malignancies, allergic reaction, and things like that. Symptoms can swell slowly or suddenly. So again, chronicity is where we can make the diagnosis, because usually infections do not go on for weeks and months. If that's going on, that's usually a lupus patient. These patients have associated depression and fibromyalgia that make things challenging, because once you ask the review of system to these patients, they will say yes to many things. And then putting the picture together and trying to figure out exactly what is going on with the patient become challenging for all of us. And there is no gold standard diagnostic test for lupus. So when we're trying to find those 4 out of 11 criteria to make the diagnosis of lupus, some of these criteria can happen, like cytopenias can happen with the infections too. So we can differentiate that. I will discuss that in a few of the next coming slides. So not having a gold standard diagnostic test for lupus, so there is not a single test in world of rheumatology which can make diagnosis of our conditions, contrary to the belief that maybe ANA is one of those tests. We have to always look at the full picture of the patient. So when would you suspect lupus patients? You see a young female with fever and rash, which is going on for a while, fever and cytopenias. These cytopenias could be leukopenia or lymphopenia, thrombocytopenia, hemolytic anemia. These are all features of lupus. Patient present with fever and chest pain and shortness of breath and may have a pericardial effusion. That may be your lupus patient. Acute renal failure, young female with unexplained acute renal failure, we must check for lupus. Fever, headache, vomiting, arthralgia, myalgia, and cytopenias, another way of lupus patient presenting. Shortness of breath and hemoptysis, lupus patients can present with pulmonary hemorrhage. So they come with coughing up blood. They are very sick looking. Their hemoglobin may be very low, maybe around 5, and they are in ICU. And you may be seeing the patient first time, and that may be a new lupus patient. So these all varied manifestations will keep lupus in the differential diagnosis. Some more pictures. This is a picture of butterfly rash, and I want you to pay attention that you can easily draw a butterfly around it, and the nasolabial fold is spared. It's very important to know this is how lupus rash look like, because there's another condition in rheumatology called dermatomyositis, which also can cause a malar rash, but that can sometimes involve the nasolabial fold. This is the sequelae of having chronic discoid rash of lupus in the ear and on the head. Some of the areas have scarring. These areas with scarring, unfortunately, have a permanent damage. This patient will not have hair regrowth there. If a lupus patient get alopecia as part of persistent inflammation without underlying rash, we treat the patient and there is regrowth of the hair. But if it is scarring alopecia, those patients will not get their hair back on the head, which is definitely something where can be very disfiguring, and also contributes to more depression in female patients. Oral ulcers, palatal ulcers in lupus patients, to remember again that they are painless ulcers. Jacquot's arthropathy, when you get a radiograph on these patients, you will notice that the bones look nice and clean, but there is a deviation. This is in contrast to rheumatoid arthritis, where we find more changes here and damage to the bone when we get radiographs. So the most common screen we do for lupus, anti-nuclear antibody. And 95% of lupus patients are ANA positive, but rheumatologists get a lot of referrals for positive ANA, and we look at the patient and they do not have any sign and symptoms suggestive of lupus. So we want to remember that lupus can be present somewhere between 8 to 10% of healthy population. It can be positive with viral infections. Also, ANA can be positive in scleroderma, Hashimoto's thyroiditis, idiopathic pulmonary fibrosis, and other chronic conditions. But when we think somebody has a high positive ANA, we check patient ANA with control serum and keep looking till the last tube turns negative. If a patient has an ANA which is reported titer greater than 1 × 2560, that's a high positive ANA. Those patients make rheumatologists nervous, they make primary care nervous, and we carefully follow them to see if they have features suggestive of lupus. So what do lupus patients have in common? They have autoantibodies against various components of their cell nucleus, and but they are also present in other autoimmune disorders as well as the healthy subject. So this test ANA is more sensitive, not specific for lupus, which means that when you have a patient with a positive ANA with all other clinical features, you are 95% confident that is a lupus patient. Because of the low specificity, ANA useful increases if the pretest probability for lupus is high, patient has sign and symptoms which can be attributed to SLE. Because of the high sensitivity of ANA, if you are seeing somebody that you think has lupus and their ANA is negative, we may have to revisit the diagnosis. It may be a different patient. I have sometimes seen a ANA negative lupus patient, but it's very rare. If you suspect lupus, you can order these tests. So frequently I get a consult on lupus patient, and people, the consulting provider, as a consulting provider, I have to tell them what labs I want, and I will tell them I want a CBC, and I want complete urine analysis and renal function panel, because we're trying to look for those cytopenias. We're trying to look for if they have any evidence of proteinuria, hematuria, which are or RBCs, WBCs, or RBC, WBC, CAS. These are all indicative of active glomerulonephritis. We want the renal function panel because we're looking if the patient's serum creatinine is normal and albumin is normal. We ask for ANA, which is positive in vast majority of lupus patients, but remember, it can sometimes be false positive. High titers are more clinically significant. If ANA is positive, then we will ask for other antibodies. Anti-double-stranded DNA antibody and or anti-Smith antibodies are more specific but less sensitive. So classic lupus patients will be ANA positive and will have either anti-dsDNA antibody, anti-double-stranded DNA antibody, and anti-Smith antibody positive. We also ask for complements C3, C4. They are often but not always low in active disease. They are acute phase reactants, so they may be high at the time of infection. So in my experience, lupus patients, the one who will drop their complements, they have both C3 and C4 low at the time of their disease flare. Most common place where these complements get deposited are skin and kidney. When we look for antibody in lupus patients, the one which give us the help with the diagnosis are ANA, which has, as you can see, high sensitivity in the slide, anti-double-stranded DNA, which has a high specificity, as well as anti-Smith. Also, phospholipid antibodies are also part of immunologic criteria, so they can be used as one of lupus criteria, and they have intermediate specificity and sensitivity. Anti-SSA, SSB, RNP are not part of the diagnostic criteria. In initial diagnosis of lupus, we check these antibodies, and then we do not keep checking them serially except anti-double-stranded DNA, because we know anti-double-stranded DNA correlate with the kidney disease or flares with lupus patient. So How do you determine when you have to check ANA? If you think the patient has the features which we discussed as a SOAP, brain MD, mnemonic, then you should check ANA. If you do not have any of those clinical criteria and you check ANA, then it may be false positive. So we should check only at the time when we think the patient has all the symptoms suggestive of lupus. So other labs to consider when patient has a non-specific symptom and low probability of lupus. Definitely look for kidney disease, check your urine analysis, urine protein creatinine ratio. We can check it as a spot. We look for CBC with differential, looking for how their white count look like. We're trying to rule out leukopenia, lymphopenia, thrombocytopenia, and neutropenia is something which can also happen with viral infections and drugs. So lymphopenia is that is more we look for lupus patient. We look for kidney disease, we look for muscle inflammation, as well as acidosis. Sometimes lupus patient will actually present with myositis. They will present with muscle weakness. And when we check their muscle enzymes, which are the transaminases, AST, ALT, LDH, CPK, and aldolase, we may find elevation in that. And these patients are fairly weak with proximal muscle weakness and not able to get up from a seated position, and sometimes may be so weak that they're bedbound. We'll check TSH in the patient who are complaining of too much fatigue because we want to rule out common causes, and hypothyroidism is much more common in females and Hashimoto's thyroiditis than lupus. And we will also ask for phospholipid antibody panel. This is usually asked in the patients who have history of miscarriages as well as history of blood clots. Looking at the kidney involvement in lupus patients, we are trying to monitor. In some of the lupus patients in the beginning of the disease, we may not find enough renal involvement, but we continue to monitor it carefully as it is one of the reasons of poor prognosis in lupus patient. We are looking for if they have persistent proteinuria for more than 0.5 gram per day, or they have cellular cast with RBCs or WBC cast, or have 10 RBCs per high field. And anytime a lupus patient's urine shows blood and protein RBCs and WBCs, it must be cultured. One of a common scenario we'll see that lupus patient, a new lupus patient, is gone to one quick care, to another quick care, to another primary care where they've been treated for a presumed UTI. And a common mistake is that we did not culture the urine, and it was not a patient with urinary tract infection. It was a patient who had persistent renal disease with lupus, and we find them sometime in acute renal failure admitted in the hospital. So anytime we find urine showing blood, protein, RBCs, WBCs, we should culture it, rule out infection. And if this is a persistent theme, we should think that this may be a new lupus patient. This is the WHO classification for lupus kidney disease. Basically patients with class 1 and 2 lupus nephritis have mild disease with mesangial change and very mild changes in the kidney. And that does not change how we manage the patient because these patients are not that sick. But if patient has focal proliferative glomerulonephritis, which may be beginning of a bad disease in lupus and renal disease. The worst one is the diffuse proliferative glomerulonephritis. These are the patients who have very bad disease with lupus. And if we are not treating them very aggressively with immunosuppression, these patients end up on dialysis. Class 5 is membranous lupus nephritis. That is also not as aggressive as proliferative lupus nephritis, but we have seen progression from class 5 to class 4 if patient is not treated in the right manner. Class 6 is sclerotic kidneys or end-stage renal disease. This is something as a rheumatologist we never want to see. We want our lupus patients to be treated and managed way earlier that they end up with the end-stage kidney disease. These are the patients who are dialysis dependent and candidate for renal transplant. And we want to manage our patients with the best of immunosuppression available, and still sometimes class 4 lupus nephritis patient end up in class 6, and will unfortunately be needing the renal transplant. With dialysis, they have high mortality, and 5-year their survival goes down. Cytopenias in lupus, COMB-positive hemolytic anemia with reticulocytosis, or leukopenia with their white cells being less than 4,000 or more than 2 occasions, lymphopenia with less than 1,500 on more than 2 occasions, and thrombocytopenia less than 100,000 on more than 2 occasions. This is how you make the diagnosis with cytopenia or blood dyscrasia with lupus. I want to emphasize here the reason we are asking these cytopenias need to be present at more than 2 occasions, because we know bone marrow can be suppressed by many things, including viral infections, medications. So if a patient has constant leukopenia, persistent lymphopenia, or thrombocytopenia, they may be one of the lupus patients. Hemolytic anemia is the same way. This is a table for one of my lupus patient who presented with pancytopenia. And you can notice that patient initially presented with leukopenia. Patient had thrombocytopenia, anemia with a low hemoglobin and hematocrit. She was started on pulse dose steroid, and you can notice that within few days, almost 2 weeks or so, everything is normalized, and her white count is normal, her platelet count is normal, her hemoglobin and hematocrit is normal. So she's responded very nicely to the treatment. Phospholipid antibody syndrome. So patients with lupus can have a secondary phospholipid antibody syndrome. We know that phospholipid antibodies are part of the immunologic criteria for lupus. And in these patients, you will have history of recurrent vascular thrombosis. So they can have history of recurrent DVT. They can have history of PE or pulmonary embolism. They can present with recurrent fetal loss. That happens because the phospholipid antibodies prone patient to have clotting, and that leads to the uteroplacental clotting in the circulation, leads to the fetal loss. These patients have a false positive RPR or VDRL, which is and also a falsely prolonged PTT. These are in vitro abnormalities. In hematology world, if we see a prolonged PTT, we're going to think about a patient with who is at risk of bleeding, like hemophilia. These patients are not the bleed risk; they are actually a clotting risk. They are more prothrombotic, but the PTT is just because lupus anticoagulant interferes how we measure the PTT in patients. They can also have Libman-Sack endocarditis, which are sterile vegetations, which can present on the mitral or aortic valve in lupus. If they have phospholipid antibody positivity, they can have livedo reticularis, and they can also have, which is more of a lacy pattern on the skin. They can also have thrombocytopenia. Thrombocytopenia related to phospholipid antibody is modest kind of thrombocytopenia. It usually stays between 60 to 100,000, and that happens because of the direct interaction of the phospholipid antibodies with the platelets. Phospholipid antibody panel should be checked completely and thoroughly in any lupus patient. That panel requires 4 components to be checked that include cardiolipin antibody, phosphatidylserine, and beta-2 glycoprotein. All of these antibodies are checked as IgA, IgG, IgM, and 4th is lupus anticoagulant. The first 3 antibodies, IgG and IgM, are part of the criteria. IgA is not, and lupus anticoagulant is described as present or absent. We should definitely check that in lupus patient, and if you find it's positive in the first setting, you have to repeat it in 3 months, because sometimes the low positivity of phospholipid antibody can be driven through infections. So we want to confirm that patient is truly positive. Lupus patients can present with vasculitis. They can present with pulmonary hemorrhage, and diagnosis is made with bronchoscopy and bronchoalveolar lavage. It will show hemosiderin-laden macrophages. These patients are treated with pulse steroid, plasmapheresis, and IV cyclophosphamide. They are very sick patients. If they are not treated on time, they have high mortality. Lupus patients also can present with wrist or foot drop, They will need a EMG nerve conduction, which will show mononeuritis multiplex. They may need a sural nerve biopsy to make the diagnosis. And those patients also will need steroid and cyclophosphamide, IV cyclophosphamide. These patients also have very severe disease. That's why they're presenting with vasculitis in the peripheral vasculitis. So when the patient you're treating has symptoms suggestive of lupus and positive ANA, it's very important to refer them to rheumatologist. And we are repeating it again when the person you're treating in your clinic, which is a woman of color of childbearing age. Lupus is not a zebra, it may be a horse. We have to definitely rule out the common condition first, like hypothyroidism, and look for, they may have coexisting fibromyalgia and depression. That definitely makes the diagnosis most challenging. A couple of other things which we want to discuss why lupus patients have high mortality. Cardiovascular risk cardiovascular disease is a major cause of death in patients with long-standing lupus. And why we have cardiovascular disease in lupus patient? One of the reasons is, unfortunately, lupus patients tend to get a lot of steroid. So the debate has been if the premature atherosclerosis is related to inflammation itself, or it's because of use of steroid. I personally think they're both contributing to the cardiovascular disease in lupus patients. So you can see a young female presenting with myocardial infarction or heart attack. In general population, you do not see female presenting that much with coronary artery disease as compared to you can see in your lupus patients. What factors which increase the mortality in patient is active lupus and coexisting infection. Of course, they are on immunosuppression and sometimes requiring too much of immunosuppression and are at risk of catching infections. They have high disease severity at diagnosis many times. Younger age diagnosis, so pediatric lupus, I see in my clinics who have 50% renal disease compared to adult patients who have 1/3 of renal disease. So younger the patient is with lupus, they may have a higher risk. African American, Hispanic, Asian, and Native American ethnicity also put them at high risk. Male gender, so we know that African American lupus patient men are not diagnosed on time, and we have found them many times in renal failure, and we have found them in advanced disease by the time we get to see them as rheumatologists. Low socioeconomic status, many of these patients think that they can't afford the treatments, they can't go to the doctors, and that's why they do not seek medical care for a long period of time. They have poor adherence to treatment protocols. So we cannot emphasize here enough that the role of the primary care, the role of the doctor that patient has more rapport with is very vital in that. We have seen lupus patients tend to do worse when they have poor compliance. And there's a challenge constantly for a rheumatologist to emphasize to them that they need to stick with their medications. They need to keep taking their medication because disease is not going to go away. It's still there, and they need to stay on medication to stay in remission. And they have inadequate support system. Many times these patients have problems in which if they need to get admitted in the hospital, they don't have enough support at home. They may have young children to take care of, and it's very hard for them to then cope with their disease. Limited education, they have less education, and it's very hard for us sometimes to explain to them that this is a chronic disease, and if we will not do the treatment in the right time, then they may have sequelae and poor prognosis. So importance of early referral. Mortality is high in patients with lupus compared to general population. 5-year survival in 1953 was 50%. Today, the survival rate is 90% because of the better detection and treatment. So lupus patients' life can be changed if we treat them on the right time, and then they can continue to have a better prognosis and live a longer life. Currently, 80 to 90% of patients with lupus survive 10 years after diagnosis, but that drops to 60% with advanced stages of organ deterioration. The leading cause of mortality are preventable with appropriate therapies. Now we're going to look at some of the cases after we have discussed the signs and symptoms of lupus. So this is a picture of 2 rashes. They are both butterfly rashes. Which one do you think is lupus? A or B?
You can put your response in the chat box or in the question and answer, and Dr. Umer, I can just call out what people are saying. We have several that have said A. Some have said both. We've had one person say B, another A, B, B, a few more Bs.
Okay.
Another
So the
A.
people who chose B, they won. The answer is B. And we can say why B is the answer. Remember, this patient has the nasolabial fold sparing. You see there is no rash here. There is no rash here and a nice butterfly pattern. Here you see the nasolabial fold is involved. So we have a lot of patients, Caucasian patient with rosacea. And also we talked about dermatomyositis, another condition where patient develop butterfly rash. So this patient is not lupus. This is a lupus patient because the nasolabial fold is spared. This area doesn't have the rash. So that's a lupus patient. Okay, so these are two hands with arthritis. And which one has Jacob's arthropathy, A or B?
We are saying, some folks are saying B, a lot of Bs, few As.
Okay, so answer is A. Remember, we talked about the lupus patients will have arthritis and swan neck deformity and will have changes which are correctable. And this is that hand with the chronic changes of lupus with Jacob's arthropathy. This patient has fixed changes on the MCP and very chronic bony hypertrophy. This is rheumatoid arthritis, and this is a lupus patient. So this is the swan neck deformities. There's a hyperextension at the PIPs and some changes here. And these can be corrected when you will, if you examine this patient and try to make the finger straight, they will become straight. But then as you will leave, they will become looking like that. This is a long-standing lupus patient with Jacob's arthropathy. Okay, so we have two cases here. Number one is 28-year-old female present with fatigue, diffuse joint pain, has joint pain for 10 years, but is worse now, has migraine, but no other symptom. Exam shows no inflammation of joint, but she has multiple tender points. Case 2 is 28-year-old female who present with fatigue and diffuse joint pain. Her joint pain started about 4 months ago and has become worse. She has noted some new sores in her mouth and has had a rash with sun exposure recently. Exam shows swelling at the PIP joints of the hands. Which one has lupus? Case 1, case 2.
Many people are saying case 2.
Okay, we got it right. So this is case 2 is lupus. Case 1 is fibromyalgia because the patient has a lot of vague symptoms, but just tender points. But here you have patient who not only have fatigue and joint pain, but also is complaining of that the patient has the joint swelling, has photosensitivity, and so arthritis and photosensitivity and rash and oral ulcers. These are all criteria of lupus. Okay, so 39-year-old woman has history of swollen and stiff joints for 1 year, MCPs and PIP with morning stiffness, referred to rheumatology for suspected rheumatoid arthritis. Patient review of system shows photosensitivity. Patient has patchy alopecia, inflammatory arthritis. White count is 3, which is low, with absolute lymphocyte count 0.8, which is low. Serum creatinine 0.6. Urine analysis is normal. ANA is positive at 1:320 titer. Rheumatoid factor is negative. CCP antibody is negative. Smith is positive. dsDNA is negative. SSA, SSB, and RNP is negative. So what's the diagnosis? Is it lupus, yes or no?
Several attendees are saying yes.
You got it right. So this is a lupus patient. You can notice patient has arthritis, patient has cytopenias, patient has a positive ENA, So ANA, one criteria, hematologic second criteria, arthritis is third criteria, and patient is anti-Smith positive, which is immunologic criteria along with photosensitivity. So that is one of a lupus patient. So the reason they're asking RF and anti-CCP here and telling you this negative, that a young African-American patient in the clinic with swollen PIPs can sometimes look like it's either RA or lupus. And then you check the rest of the blood work, and you do autoantibodies, and then you figure out this is not a rheumatoid arthritis patient, this is a new lupus patient. Okay, next one. 33-year-old African-American woman present with inflammatory arthritis, positive ENA for 4 years. 1 year ago had pericardial and pleural effusions, resolved with prednisone. Now have fever, cough. Lab shows a creatinine of 3.8, so patient is in renal failure. White count 3.4. C3 is low at 61. C4 is low at 9. 3.1 gram protein urea. Urine analysis shows large blood. Autoantibodies include ANA, double-stranded DNA, SSA, SSB, RNP, all of them are positive. Other symptoms include photosensitivity, Raynaud's, pruritic rash, oral ulcer. Is it a lupus patient, yes or no?
Several attendees are saying yes.
You got it right. This is another lupus patient. So this patient has a positive ENA as one of the criteria. Hematologic criteria is leukopenia, has arthritis, has immunologic criteria, dsDNA is positive, is photosensitive, is having mucosal ulcers, oral ulcers, renal disorder. Patient has so much protein urea and a creatinine of 3.8. So patient is having active lupus nephritis. Patient has serositis and low complement. So there are many criteria here, and this is one of a sick lupus patient because she has major organ involvement in the form of kidney disease as well as history of serositis. Case 3. So this is the tricky one. 43-year-old Caucasian woman comes in wanting a lupus test. She has read about lupus and is convinced that she has it. Symptoms: she aches all over her body, feels tired all the time. This has been present for a while, but worse over past year, has trouble sleeping, and does not feel rested in the morning. Past medical history, migraine headaches. On physical exam, there are no swollen joints, no rashes, no oral ulcers, multiple soft tissue tender points. Should you order ANA now? Yes or no?
We have some attendees saying no. We've had 1 or 2 attendees saying yes.
Okay, so the answer here would be a resounding no, because the patient doesn't have enough criteria for lupus. If we check ENA in this patient, it did come back positive. We stuck with that positive ENA, maybe a false positive ENA, because there are no symptoms suggestive of lupus. She has vague symptoms of myalgia, tiredness, doesn't sleep well at night, may have sleep apnea, may need a sleep study, and just having tender points. So this could be one of a fibromyalgia patient. She does not have lupus. He doesn't have enough clinical features suggestive of lupus. Okay, so in summary, early symptoms can be non-specific and can be mistaken for other illnesses or syndrome. Symptoms can be transient or prolonged and independent of one another. Consider lupus in the patient if the symptoms are many systems involvement, and then patient is having symptoms for a while. Also consider lupus if patient also have a strong family history of autoimmune disease, and they may tell you they have family member or extended family member with lupus. And the initial screening is pretty basic. You will check a SADRID, CRP, you'll check CBC and a CMP or a BMP with LFTs, and urine analysis. In most of the centers, these basic labs are available. So if you find a lupus patient, they will have a high SADRID. CRP usually doesn't go high with lupus during the flares. They will have cytopenias, they will have a low serum albumin, they may have high creatinine if they have kidney involvement, they may have urine showing blood protein, RBCs, WBCs, or the CAST. If none of those things are present there and patient has no clinical features suggestive of lupus, you should not check ANA. But all those things, if there are abnormalities there which favor the diagnosis of lupus, you should order antinuclear antibody, which in many centers will reflex to do the rest of the autoantibodies. And the 3 immunologic antibodies you have to check if you truly are seeing a lupus patient include anti-double-stranded DNA, anti-Smith, and the phospholipid antibody panel. Anti-Ro and La is also checked in many centers as part of autoantibodies, and they are considered part of Sjogren's syndrome. Secondary Sjogren's syndrome can coexist with lupus patient, but remember anti-Ro and La are not part of the diagnostic criteria. Refer to the patient for assessment and diagnosis when you find a lupus patient. We're going to move on to the medication in lupus. Let me quickly see, we're doing time-wise, we're doing good. So the learning objective of discussing the medication in lupus is we should discuss what is our approach to medication in lupus with the case studies to assist. We will see how the management is changed with the severity of disease. We should underscore the role of corticosteroid, which play in the morbidity in SLE, and discuss situation where increasing steroid may or may not be beneficial. How can we minimize steroid use? So a rheumatologist's goal or dream is to get lupus patient only that much medication or steroid by which their disease get in control, but we do not want to give them steroid for a long-term basis. So we want to use lowest effective dose, and we should discuss the strategies to assist with medication access for uninsured or underinsured. So medication for lupus, there were no drugs FDA approved from 1958 to 2010, which is a big challenge for rheumatologists. The only 4 drugs which are FDA approved are aspirin, corticosteroid, hydroxychloroquine or Plaquenil, and now belimumab or Benlysta. But we have off-label use many other medication in lupus that include azathioprine, mycophenolate mofetil, cyclophosphamide, methotrexate. The goal of therapy in lupus is we want to look at a risk-benefit ratio. We want to control the active disease and prevent the joint damage. And we want to avoid the toxicity of the medication, especially steroid, and target therapy to the organ system involved. So what with the disease activity, the important determinant is we look for how much a persistent disease is there for ongoing immunosuppressive therapy. And it's defined by what manifestations are present at the time when you're seeing the lupus patient. So lupus patients may have damage or they may have disease activity. And the role of rheumatologist always is to figure out how much is the chronic damage and how much is the persistent activity so that we can tailor immunosuppressive therapy according to that. There are 2 major types of symptoms from lupus, which are each treated differently: activity and damage. For damage, there are so many things that you can do. Some of the damage may be permanent to the organs, but for activity, we always see there is room to act, and we will start with immunosuppression. So to give example of how we can differentiate between activity of lupus and the damage is that we give example of a forest, which is your body, and the fire in the forest is the immune system. And the immune system here, when you're seeing a small area of fire, is used good for the body. But if this fire goes rampant and it goes out of control, it can start attacking the forest, which is the body. And that's the sign of overactive immune system causing damage to the own body. So the medication we use in lupus are considered kind of water, and that is basically trying to put that fire out for the overactive immune system. Now, after many years of flare, the damage remains. So it's a problem because it was caused by the fire. However, now it does not respond anymore. So the damage may still be there, and our job is to try to figure out how to help the patient to cope with that damage and prevent further disease activity. Recovery from the damage may be slow and incomplete, but there is always hope. So when lupus patients, one of the biggest frustration is that when lupus patients think that they are permanent damage, that will also improve. And sometimes when their symptoms don't completely go away over time, then they think that the medications are not helpful, they are not doing the job. And so those patients will tell you, I feel bad, I feel terrible, but you're telling me my labs are fine. So they have had some damage related to their disease. And we are trying to give them some medications to get the disease under control, and it takes little time. And we have to explain to the patient symptoms develop over weeks and months. So the medication is not going to get you better over time. We'll have to take a slow pace and we will improve. So anytime when patient has activity or damage, these are important and real issues, and the medical team need to address it together, and we will have to treat it differently. And there is so much time is a multidisciplinary approach. If patient has kidney disease, they will be seeing rheumatologist as well as nephrologist, and we will try to make a plan together that if the patient need to continue to stay on that much steroid or not, if the patient would be needing more therapy in the form of cyclophosphamide, mycophenolate mofetil, or Celsap to keep their disease in good shape or control. So steroid, unfortunately, among all the medication we use in lupus, steroid is still the mainstay of treatment. Why? Because steroid are the fastest acting medicine. We call steroid as frenemies. They are friend for short term, they are enemy for long term. So we want the lupus patients to be on steroid and high dose steroid. We give them IV steroid called pulse steroid when they are very sick, admitted in the hospital. But we try to taper the steroid down as much as we can and put them on a lowest effective dose. What is a lowest effective dose? 5 milligram of prednisone daily. So patients who are on long-term high-dose steroid, they will have many side effects. They can have appetite issues. They eat a lot and have the weight gain because of the steroid. It can cause issues with having trouble sleeping. They have mood swings with high doses. It can cause high blood pressure, can cause high glucose, and make them even steroid-induced diabetics. They can also have increased risk of osteoporosis. It can cause gastritis, peptic ulcers. Patient has accelerated cardiovascular disease and cataract formation. So in the lower dose, these effects are less likely. Patients also have risk of infection. I've seen shingles developing in lupus patients when they stay on high dose steroid. So we try to again cut down steroid to the lowest effective dose. Many other complications of the steroid that we see is that these patients will have Cushing-like appearance. This is very important for younger patients because it definitely gives them the further lower self-esteem, and they don't look good and they look Cushing-like with steroid use. Time and again, we have to explain to them that don't worry, this changes in your face or the weight gain that you're getting with steroid. Once we get the steroid down, it will improve, and you have a life-threatening manifestation with lupus right now, which may be kidney disease, which may be brain involvement, which may be pulmonary hemorrhage, and you need steroid for that. These patients can have increased risk of GI bleed, especially if they take concurrent non-steroidals. So we actively tell and encourage our lupus patients to don't take non-steroidal regularly. There are many reasons for that. One of them is they may have kidney disease, and non-steroidals are not a good idea. They can have hepatitis-like picture with non-steroidals, as well as they can have aseptic meningitis. Hypertension also can happen when they are on high-dose steroid, although it can also be driven through their kidney disease. Their lipid abnormalities can be there. We discussed premature atherosclerosis already, that these patients, the higher dose of steroid will put them at risk of having coronary artery disease. They have skin thinning, myopathy, risk of tendon rupture. Also, lupus patients could develop withdrawal syndrome or adrenal insufficiency. So all lupus patients, we educate them when they are on high dose steroid that they cannot stop their steroid cold turkey. They have to reduce it slowly. If they are on high dose steroid for more than 2 weeks, they cannot stop their steroid right away because it will make them feel very sick. So pulse dosing we use in early severe disease, and we will then gradually taper. When we are tapering these patients, they get started on DMARDs, which are disease-modifying anti-rheumatic drugs, and that include mostly medications like Plaquenil, hydroxychloroquine, azathioprine, or mycophenolate mofetil. We do not use more than 5 to 10 milligram per day dose chronically in lupus patient. Most of our lupus patients are on our lowest effective dose, which is 5 milligram of prednisone. We may give them sometime a little bit increased dose of 10 to 15 if they are in an early flare like active arthritis. Also, if they have pericarditis and things like that. So then early increasing a small amount of steroid prevents them from taking high dose steroid with a big flare. The first line therapy among the DMARDs in lupus patients after we have given them steroid is anti-malarial. Hydroxychloroquine is the most commonly prescribed anti-malarial medication. Chloroquine is also available, but is much more toxic, so we do not use that. And hydroxychloroquine was derived from bark of cinchona trees, analogous to quinine. It was first used in SLE in 1894, so it has been a time-trusted medicine for many years. What it does basically, it raises the intracellular pH, and it basically turns off the receptor activation site. It prevents the activation of toll-like receptor 7 and 9. These are the areas of research for ongoing more lupus therapies. This medicine has a long half-life. So what Plaquenil or hydroxychloroquine does is it controls the skin symptoms and joint disease. It's a good mucocutaneous medication. It will prevent the long-term damage with the kidney disease and brain involvement. It has a protective effect on the survival in lupus. It lowers the fasting glucose in women with SLE taking Plaquenil. It has a mild antithrombotic property. So we believe that Plaquenil or hydroxychloroquine helps the lupus patient to not have flares. It also has a favorable effect on the lipids. So all lupus patients, they are on Plaquenil if we can do it. Sometimes the treatment on hydroxychloroquine is delayed if they are in a very big flare in ICU and we're giving them more bigger immunosuppression like cyclophosphamide and IV steroid. But once they are in more stable mode, we will put them on hydroxychloroquine. One of the contraindication to use that in is patient with G6PD deficiency, so we check for that. This medicine also may have a role in preventing congenital heart block, which can happen to the babies of patients with lupus, especially if they are positive for anti-Ro and La. So we now encourage our lupus patients who are pregnant to stay on hydroxychloroquine during pregnancy. This is the picture of neonatal lupus. This is a baby of a lupus patient. You can see how much rash patient has on the face. This baby doesn't have lupus. It's a misnomer neonatal lupus. Basically, the baby has transplacentally acquired maternal autoantibodies, and that's causing rash on his face. This usually, most of the symptoms of neonatal lupus go away within first 6 months of life, except heart block, which can be irreversible. So all lupus patients are high-risk OB patients, and they are carefully monitored, and their baby's heart rate is also carefully monitored. We notice that when lupus patients stay on hydroxychloroquine, they have less flare. This graph is showing you that if a patient stayed on placebo versus Plaquenil, then Plaquenil patients tend to have less flares. This medicine is very safe in pregnancy. There's no blood test needed for the monitoring. It's not that immunosuppressive either. It does not impair the wound healing. The only problem with Plaquenil is if a patient has been taking this medicine for more than 5 years, there is a concern of retinal toxicity. Some other rare, and that's why we want all our lupus patients to have a yearly eye exam, sometime even earlier than that, every 6 months if ophthalmologist wants. We also every once in a while see that patient who are on long-term hydroxychloroquine may have side effects in the form of either skin discoloration, or they can have sometimes complain a little bit of dizziness. We always will check EKG on that patient to make sure they don't have any QT prolongation. Cardiomyopathy with hydroxychloroquine is very rare. GI symptoms, some patients will complain of diarrhea and will adjust the dose of hydroxychloroquine for those patients, again, very rare. And CNS manifestation more in the form of dizziness is overall a very safe medicine for lupus patient. So risk of toxicity with Plaquenil increases after 5 to 7 years of use, but still it's only 1%. So baseline eye exam, and to rule out the changes or maculopathy is needed. Annual screening should begin after 5 years and sooner if patient has risk factors. There are multiple modalities which are being used by ophthalmologists to make sure they don't get plaquenil or hydroxychloroquine toxicity. That include things like spectral domain optical coherence tomography or OCT and multifocal electroretinogram. So we have specialized retina specialist ophthalmologist in our institution where we send our lupus patient for plaquenil eye exam. They also need to look at their field, visual peripheral fields, because that can get affected with long-standing plaquenil use. Amsler grid is something in which we can ask the patient to look at the words, and if they start seeing some blurring, then we can think they have plaquenil toxicity. That was our old way of looking at plaquenil toxicity. We do not recommend that because by the time the changes are that pronounced or and that advanced that patient cannot see well is too much of plaquenil toxicity. We should stop it before that. So bull eye maculopathy is a late change on the fundus exam with people who are on long-standing plaquenil. Should not happen. We stop plaquenil before that if a patient, God forbid, has that. We do not have many lupus patients in which we had to stop it because of the ocular toxicity, because we use it within the recommended dose. We use 6.5 milligram per kg dose. And nowadays we have started changing it to 5 milligram per kg for patients who are either less body weight or people who are having advanced age with lupus, and we want to make sure they don't get any maculopathy. These are just the eye exam pictures, just showing you the detailed eye exam for plaquenil. We emphasize to patients to see ophthalmologist just for their eye exam when they are on hydroxychloroquine. Azathioprine, Amarin, is another medicine which can be used in pregnancy, and it is a useful medicine for maintenance for many lupus manifestations, include lupus nephritis, and will help us to do steroid sparing. It's also used for cytopenias and helps those patients. It has its own toxicity if it's not used, and if we use the much higher doses. The things that we monitor with azathioprine is we always check the enzyme thiopurine methyltransferase. That is the enzyme which is involved in the metabolism of this medicine. And if it is low, then we will not give patient azathioprine. The other risk with this medicine is long-standing use, bone marrow suppression, which is again rare. Patient can have sometime nausea, vomiting, headache, or fatigue with azathioprine, and risk of pancreatitis. So patients know who are on azathioprine, they have very severe epigastric pain, they should call their rheumatologist. Mycophenolate mofetil or Cellcept, it is a teratogenic medicine. It's not recommended in pregnancy. It targets the lymphocyte preferentially. It's useful in lupus nephritis, in lung disease, in other severe manifestations. We use it for skin disease when it's very bad in lupus patient. We also use it for myositis. It gets a lot of lupus manifestations improved by using mycophenolate mofetil, and help us for lupus patients to not stay on high dose oral steroid. These patients toxicity wise with mycophenolate mofetil, if we use it in lupus patient, the main problems we watch for is leukopenia, predominantly neutropenia. These patients can have sometimes nausea, vomiting, diarrhea, especially if we are using the max dose. We use the medicine as a dose of up to total we can use up to 3 grams in a day. And we start with 500 milligram twice a day, and we can go all the way up to 1500 BID. And at the dose of a gram BID, most of patients tolerate fine. Higher dose may cause some GI symptoms. If patients are allergic to this medicine, they can have a rash, and we educate patient about that. Cyclophosphamide, which is chemotherapy, it has been used for lupus for a long period of time. In the initial NIH trials, when we were trying to learn how to treat these lupus patients in a better form, we gave them up to 2 years of Cytoxan, which was very toxic. With more studies on board, we have figured out that lupus patients benefit from IV cyclophosphamide therapy, but we try to limit it not more than 6 months or so. And patients will be getting either high dose monthly dose IV every month for 6 months, or they may sometimes get low dose every 2 weeks for a few months. That's a Euro-Lupus trial. And these medications, cyclophosphamide is usually given to lupus patients when they have kidney disease or brain involvement. We have used oral cytoxin or cyclophosphamide in the past in lupus patient, but we know it's much more toxic. So we are getting away of not using that. We check in these patients CBC before we give them the medication because this medicine drops the white count. And we check the nadir labs 10 to 14 days after we have given them cytoxin. That help us to tailor the dose. We will use 500 milligram per meter square dose. We'll go 10% up or 10% down, and sometimes reduce dose further than that if the patient has bad neutropenia or leukopenia with this medication. Some of the side effects of the cytoxin or cyclophosphamide are bone marrow suppression, nausea, vomiting, alopecia. It's very teratogenic. There is also a concern of that the patients can have decreased fertility. If we use cyclophosphamide in a female of above age 35, there is chances they go into premature menopause. And we discuss that extensively with the patient because it will affect their fertility. Hemorrhagic cystitis is one other side effect of cyclophosphamide. We use Mesna when we give cyclophosphamide to lupus patient. There is a product of cyclophosphamide that goes in the bladder and it can cause bladder cancer. That's why Mesna is given very generously to these patients during the time we give the infusion. Long-standing risk of lymphoma, as well as patients who are on intense immunosuppression with cyclophosphamide are at risk of infections. When we give patients cyclophosphamide for lupus patient, they are not on any other DMARDs because it itself is a very strong immunosuppressive therapy. They may be on steroid and cyclophosphamide, no other medications. Methotrexate is sometimes used for arthritis of SLE. It's not effective for other internal organ involvement. The dose is same as we use for rheumatoid arthritis, up to 20 milligram PO or 25 milligram under the skin subcutaneously once a week. It's given with folic acid 1 milligram daily. Toxicity of methotrexate could be bone marrow suppression, GI involvement, alopecia, photosensitivity, and it's teratogenic. I would recommend and advise if a lupus patient has had history of cytopenias, then methotrexate may be a little tricky choice because it can cause bone marrow suppression in its own. So we can use other medications to help with arthritis than methotrexate. Some of the new targeted therapies for lupus are the B-cell directed therapies like rituximab. We use rituximab quite a bit in our lupus patients, and cytokine inhibitors, medicines in the form of Benlysta, belimumab. We have next coming slide talking about it. And some others are in the pipeline, kinase inhibitors, peptide inhibitors, T regulatory cell, and co-stimulatory blockade. So abatacept, which blocks the T cell co-stimulation, is also being studied for lupus. The one which are FDA approved is belimumab, and we use rituximab as an off-label medicine for lupus patients. What are the complications of these medications? Much more risk of infection, so we carefully monitor these patients and we'll treat their infection very aggressively if we find a coexisting infection. The biggest infections I've seen with the medications given to lupus patients are shingles, and we treat those patients sometimes with IV acyclovir if they are hospitalized or by mouth, PO acyclovir if they are outpatient. There is also risk of cancer with cyclophosphamide therapy. When the patient has sometime, if they are pediatric lupus, they may go through IV cyclophosphamide therapy or cycle 2 to 3 times in their life. The risk of infertility is higher when the older patient gets cyclophosphamide, and then teratogenicity. So these are females of reproductive age. We make sure they are on medications which are safe in pregnancy if they're planning to have start family, and they're very well aware of they are on cyclophosphamide or they are on CellCept, they are not supposed to get pregnant. We tell the patient with kidney disease they have 6 months. They need to have 6 months of good control of kidney disease before they anticipate pregnancy. Biologics definition, these are the substances which are made from living organism and products and used in the prevention, diagnosis, and treatment of disease in humans. Biologics include antibodies, interleukin, and vaccines. These have made a big breakthrough in world of rheumatology. Post-biologic era have made a big difference in many conditions. So the only biologic we have for lupus right now is belimumab, and Benlysta is FDA approved in 2011. It's a monoclonal antibody or B lymphocyte stimulator. There were 2 trials in which they enrolled the lupus patient. There were a lot of Caucasian patients in this trial. They excluded patients with bad kidney disease, brain involvement, or pulmonary hemorrhage. And when they give this medicine, it's given as 10 milligram per kg at 0, 2, and 4 weeks, and then we give it every month as IV infusion. And so when we started using that in our patients, we noticed that it helps them with they have refractory cutaneous disease. There is some data coming out that it is also helpful for kidney disease, but is not as potent of a drug for proliferative lupus nephritis yet. It's also now available as a sub-Q form. Some non-pharmacological interventions that we do for lupus patient, we tell them, please protect yourself from sun, because we think that the sun rays damage their skin, which leads to the autoimmunity. We look at the cascade earlier. We discussed that they avoid sulfa-containing antibiotics because their skin is sensitive. They are much prone to have allergic reactions and sometimes having Stevens-Johnson syndromes. Avoidance of immunization with live virus. So if a lupus patient is on more than 20 milligram of prednisone, we should never give them a live virus vaccine. We encourage them to do smoking cessation because they are already at risk of premature coronary atherosclerosis. All standard immunization should be given. We monitor their lipids, blood pressure, and bone density. Birth control, once quick thing on that is that patient, if they are APL positive, they cannot be given estrogen containing products. We should use the alternate method of contraception. We also encourage them to exercise and do physical activity and improve their diet in a healthy form, because they definitely will have more problem with the chronic use of steroid and weight gain. What vaccinations are good for these patients that you should give include the Prevnar and Pneumovax and flu vaccine. Vaccines which should not be giving them is live vaccines like MMR, varicella, zoster, or Flumis. Now, actually, we have an inactivated zoster vaccine that would be okay to give to lupus patient. We have a lot of work that need to be done in lupus. We are so behind in lupus management compared to other conditions in which we have made we have come a long way and make good stride. Why we are having trouble getting lupus patient in good control? Because the trials always lack the heterogeneity of the disease, make it hard that we cannot, as you cannot compare apples to oranges. You cannot compare lupus patient with different manifestation and use the same drug. One size doesn't fit everyone. One treatment doesn't help every patient. There is also a little bit of a concern, how much is disease activity and damage and flare. We also need to see what is the choice of background therapy. When we are using a new medicine on lupus patient, we need to see how much steroid we can give, because it may be steroid which was making the difference. And remember, we're trying to get away from giving them high dose steroid. Trial design, how we make a best trial to help us. Are we looking for superior drug or non-inferior trials? Sample size, always how many patients we enroll so we can see the better outcome and efficacy of the drug. Ethnicity, that's the biggest challenge. There has been always a trust issue and getting the patients, African American and Hispanic patients, to be enrolling in the trials. And when we get the medications approved and they're only given to Caucasian patients and they're not given to African American and Hispanic patients, we know those medications will not work well on our patients. And we need to measure the side effect of all these medications. So research in lupus is ongoing, and we certainly hope as rheumatologists to have more treatments available for lupus patients. The goal is to not give them that much steroid as we are giving right now. Medication success, I'll just quickly skip this slide, but there is the expense of the medication, depending upon somewhere between $80 to $100 per month for one medication, and we are giving patient multiple medication, and we know biologics are very expensive. I want to say here that if you have a lupus patient that you know who is struggling to get these medication, find a nearby tertiary care center, because they will have resources. They may even have patient assistance program, which is sponsored through pharmaceutical company, but it does help your poor and indigent patient, and they will continue to get their treatment, which is very necessary to keep their disease under control. Do we have time to go for the cases?
We are out of time now, but what I was going to suggest is we do have a few questions, and Dr. Umer, if you're okay, I can get those questions to you and you can email back answers to us, and then we will send out, will that work?
Yeah, I think that will work. I'm going to quickly just show the summary. Lupus is a heterogeneous condition. Treatment depends on organ involvement and severity. Goal is to minimize the medication toxicity, especially when we are considering to give steroid to them. And more pathogenesis of lupus will be recognized. We will have more success to get better targeted treatment. But remember, these patients benefit from Plaquenil or hydroxychloroquine. I appreciate you registering for this webinar and listening to about lupus and complexity of this disease. And I'll be happy to answer any questions if they're sent to me by email. Sorry, we didn't have enough time to answer the questions.
No problem. Thank you all so much for joining us on behalf of NAO and the Lupus Initiative. We thank you, Dr. Umer, for this wonderful presentation. I've placed in the chat box a link to the evaluation. You will also get this when you close out of Zoom, and we will also email this. After you complete the evaluation, you'll be able to print and save your certificate, and then you'll be also directed to the post-test. We will also be sending next week the recording of today's training along with the answers to the 3 questions that came in during the question and answer box and the chat box. Thank you all so much, and we hope you have a wonderful afternoon and a great weekend.
Take care. Bye-bye.
Bye, everybody. Thank you again.